Well, good afternoon, and welcome to today's event, Regulating a Miracle, GLP-1 Costs, Access, and Safety, hosted by the National Academy of Medicine. I'm Alex Azar, and I'll be your moderator for what I'm sure is going to be a very interesting conversation. Today's webinar is part of a new series, Health in the Headlines, which was launched to share reliable information and different perspectives on high-profile and sometimes controversial health issues. Each session brings together a panel of experts to model a kind of public dialogue that acknowledges uncertainty, respects differing viewpoints, and distinguishes between evidence and values. So you may hear our speakers clearly identify not only what the research tells us, but also where personal or policy values come into play. Today's event is about a new class of drugs you may have heard called a, quote, miracle, end quote. Over the past few years, GLP-1 receptor agonists, drugs like semaglutide or Ozempic and Wegovy, and tirzepatide or trade name Mounjaro and Zepbound, have emerged as a game changer in diabetes and obesity care. Originally developed to help regulate blood sugar in people with type 2 diabetes, these medications were later found to produce substantial weight loss. Full disclosure, I was the president of Lilly USA, the U.S. affiliate of Eli Lilly and Company, prior to being secretary, last working there almost 9 years ago. I have no ongoing employment or financial relationships with them other than being a defined benefit retiree. Today, GLP-1s are being prescribed far beyond diabetes. For obesity management, where they have been demonstrated to significantly reduce body weight, for cardiometabolic health, with growing evidence of benefits in cardiovascular and kidney outcomes, and increasingly in off-label contexts. Their rise has been meteoric. In just a few years, GLP-1s have gone from niche treatments to household names, driven by celebrity endorsements, media hype, and surging demand. Yet this success has also exposed deep controversies and challenges. Prices often exceed $1,000 per month. Long-term safety and duration of use remain uncertain. Access is uneven. And the ripple effects from healthcare to the food industry are only beginning to emerge. We've invited an outstanding panel of speakers to help us explore these issues from multiple angles, all grounded in research and real-world evidence. Throughout the event, we invite our audience to join the conversation as well. If you have a question for the speakers, please submit it at any time using Slido, which you'll find embedded just below the video player on this page. Today's event is being recorded, and all attendees will receive a link to the recording when available. Thank you for being here. Now let's dive in. To start off, I'd like to ask each of my guests to introduce themselves and tell us a little bit about their background with regard to GLP-1s. Because this event is also about understanding how values shape the application of research and policy interventions, I'm asking our speakers to identify the primary goals or values that drive their work in this area. Just by way of background on myself, as I mentioned, I was the president of Lilly USA, the largest affiliate of Eli Lilly and Company based here in the United States. And then I was for 3 years the U.S. Secretary of Health and Human Services under President Trump from 2018 to 2021. For me, as I think about GLP-1s, I am excited about their prospect to help us deal with chronic disease, to help us reduce costs in the healthcare system, and perhaps be something that could dramatically change our approach to preventing disease here in the United States. But I'm interested in hearing our panelists talk about the other sides of the coin, what the concerns and risks may be also. Jamie, can I turn to you next to kick us off with your introduction?
Great. Thank you so much. Good afternoon, everyone. My name is Jamie Almendoz. I'm an endocrinologist and a professor of medicine at UT Southwestern in Dallas, where I also serve as medical director of the Weight Wellness Program, which is a large multidisciplinary obesity medicine program. My research interests include factors impacting utilization and outcomes with obesity medications and bariatric surgery. And for context, I view obesity as a chronic, biologically mediated disease that deserves the same longitudinal care framework as hypertension, heart failure, diabetes, or other accepted chronic diseases. My approach to care really integrates pharmacologic, surgical, behavioral, and systems-based strategies to maximize patient outcomes while promoting equitable, evidence-based access. Thank you.
Wonderful, Jamie. Thank you very much. Govind, would you mind introducing yourself next?
Sure. My name is Govind Prasad. I am an associate professor of law and also philosophy at CU Boulder, where my research focuses on health law and medical ethics. And I also have the honor of currently being the 2025-27 National Academy's Greenwall Fellow in bioethics. My approach to this draws on both my interest in bioethical issues related to medical resources in short supply, and also issues around innovation policy and the design of health insurance systems and health financing. I approach this through the lens of being really interested in the potential of these drugs and appropriate ways of financing and creating incentives for development in this space, both to advance societal and patient level benefit, both directly to those patients and indirectly to other individuals and society at large. And then also their potential, again, if policy is well designed in this space, to mitigate health shortfalls experienced by people that are more disadvantaged along a variety of axes.
Great. Thank you very much. Jeff, would you go next, please?
Sure. My name is Jeff Singer. I'm a general surgeon in private practice in Phoenix for the last 40 years, and I have a couple of my associates do a lot of bariatric surgery and have noticed that the volumes drop recently. But my principal interest in this is I'm also a senior fellow at the Cato Institute, where I work in health policy studies, and I have focused a significant amount of my time in the last 9 years in areas about dealing with substance use disorder, the overdose crisis, and also FDA regulatory reform. And what got me very interested in this subject is the fact that there's been a lot of early, albeit early, evidence that GLP-1s might be effective in helping to treat various substance use disorders and even compulsive disorders. And it might even, there's some very early evidence that it might even have the potential as a medication-assisted treatment for stimulant addiction like cocaine and methamphetamine, for which there is no medication-assisted treatment yet. So that's what got me very interested in this. I have a book out that came out in April called Your Body, Your Healthcare, where I emphasize my focus on the presumption of autonomy when addressing healthcare policy issues.
Excellent. Thank you, Jeff. Tracy, you want to round us out, please?
Thank you, and it's great to join you this afternoon. So my name is Dr. Tracy Zvenich. I have a background in health policy research, as well as I teach health policy and advocacy at Georgetown. I'm with the Obesity Action Coalition, and OAC is the leading nonprofit representing patients, so people living with the disease of obesity. We just celebrated our 20th anniversary. We serve over 90,000 members nationwide. And we really fulfill our mission through support, education, and advocacy. And much of our advocacy focuses on improving access to care. So the innovations of GLP-1s coming into this space have provided hope to our patient community, where safe and effective treatments haven't been as widely available until the last few years. So from an advocacy perspective, we advocate for the full spectrum of care, so everything from nutrition, lifestyle, pharmacotherapy through endobariatrics and surgery, but we're really trying to address the barriers to care, whether it's cultural or policy, to improve that access to evidence-based options.
Great. Thank you, Tracy. Well, let's get started. We'll talk about costs and access first, and then we're going to get into safety and ethics. My first question is this. GLP-1s are among the most expensive chronic use drugs on the market. What do we know about their cost effectiveness in real-world settings? Do they lower healthcare costs? And how should insurers decide who gets coverage? Govind, would you like to start? And then if we could hear from Jeff, Tracy, and Jamie in that order, please. Thank you.
Sure. Yeah, so I may ask you to refresh my memory whenever there's a multi-part question. Yeah, what I would say is that you asked the question, I think, in a really great way, the very first question, which is, what do we know now about their cost effectiveness? And then you added in real world settings. I think we're increasingly getting positive signals of improving cost effectiveness findings. I believe the Institute for Clinical and Economic Review in the US just did a reassessment of one of the GLP medications, I forget which one, and found much improved cost effectiveness. Now, as you and others may know, cost effectiveness is often put in terms of a binary, it is or it's not. Really, it's about how cost effective it is, so how much it costs relative to benefits. So I think in the data that ICER looked at, I think it is looking more favorable. I think one question and one of the challenges we have, not only us, but in every health system is particularly, I think, acute here, is what the incentives are to generate that data, now looking at sort of longitudinally cost effectiveness over the long term, looking at it pragmatically in real world settings. But I feel very optimistic about that, but I don't think there is more empirical data that I would like to see developed, not as we need to wait to pay for this until we have the data, but I would like to see mechanisms to drive the generation of that cost effectiveness information. And frankly, in the US, I think we often struggle with that because we don't have that incentive to keep doing those studies. There's no organization that has the incentive to be doing that. You asked also about reducing healthcare costs. And again, I think the question is a great one and is sort of from whose perspective. I think that there's a lot of potential for it to reduce certain healthcare costs that are attributable now to, as it were, dealing with, I believe Tracy described, and others as well on the call, sort of thinking about folks managing a chronic disease, and to the extent that it can mitigate costs, both in terms of medicine and in terms of people not being able to do things that they value. I think it can be immensely beneficial in both those domains. I think one challenge is, who is bearing those costs as the payer versus who is the person down the road who is going to either save as society in not paying for some costly procedure. And, you get tricky things here because I remember some on this call may know the data on it more. There are different findings about whether reducing the incidence of smoking reduces healthcare costs. It depends on over what timeline and whether you think of somebody dying prematurely, which I think of as one of the worst things. From a different payer perspective, it may not be so bad. So I think my overall takeaway really is that I think that there is a lot of promise both for cost effectiveness, reducing healthcare costs, and enabling people to do the things that they want to do in their lives. I think what I want to see, while not holding up the ability to, enhance the use of it, is also to continue to generate and incentivize generating that empirical data about what the benefits are, what the costs are, and recognizing that costs also, are not fixed. Monetary nominal costs depend on a lot, and who's paying depend on factors about insurance, about pricing, about regulation.
And just Jeff, before we go, just to repeat the sort of two-part question. The first was, what evidence do we have around cost effectiveness / do we have information that would demonstrate that these drugs can lower healthcare costs? And then the second was, and Govind had a good way of talking about this, how should insurers decide who gets coverage, really highlighting this cost benefit time discontinuity that we have in the United States healthcare system of who's willing to invest in something when someone else in a longer term might yield the benefits of that. Jeff, let me turn it to you.
Sure, thank you. Well, I would agree with Govind that we don't have a lot of data yet, but it would just make sense that if we have a drug that is reducing the complications of diabetes and the complications associated with obesity, then there should be what I would like to kind of frame it as, it should contribute to a decrease in the trajectory of healthcare spending. That's the way I would prefer to phrase it. And like I said earlier, I'm quite excited about the potential that GLP-1s could be used also for substance use disorders, there's a lot of evidence already on things like smoking and alcohol. And those two lead to reducing those disorders will reduce expenditures. We're not going to know this, until we start having this around for a while, long enough where we can really collect some quality data. Now, as far as what insurance companies should do, I'm of the view that insurance companies should make their decisions based upon what's in their best interest. And if they're persuaded that covering GLP-1s will, in the long run, save them money, then, more power to them. But I also probably have for this panel, a controversial position that I've written about, which is that I would like to see GLP-1s reclassified by the FDA as over-the-counter drugs. I think, and we could talk about this later, it could do a lot towards reduce. Our experience has been when drugs become over-the-counter, prices tend to drop. There's more price competition. There's more consumer investigation and price comparison shopping. And we already see some evidence now because with the entry of new products onto the market and competition from online sites and companies like Noom and Hims and Row.com, we're seeing already the makers of Zepbound and Wegovy lowering their prices in response to that. So I would like to see these drugs eventually be made over the counter, and we could talk about later about the pros and cons of that.
Great. Good issue to introduce. It'll be certainly worthy of discussion. Tracy, how about you next?
Yes, thank you. So I agree. There is growing evidence on cost effectiveness. A few papers and analyses have been published this year. One recent paper found about 39,000 cardiovascular events were avoided with access to obesity treatment. Also improvement in chronic kidney disease or MASH, liver disease. In another analysis, I think one done by Milliman, found fewer hospital admissions for spine surgeries, joint replacements, other cardiovascular surgeries. So, and they also found reductions in ER visits for diabetes complications, stroke, pulmonary conditions, etc. So we are seeing some early data on these savings and cost effectiveness. Now, I think, building off of the comments from my colleagues here, we need to work more on engaging with payers and insurance companies to better model and understand where and how they are seeing the ROI kind of across their books, whether that's in reductions in medical spends or pharmacy spends. So new modeling is needed in this therapeutic area, because it's just, given the innovations and the broad reaching indications, we have to start looking at this differently.
Great, thank you. Jamie?
As a clinician, hearing Govind kind of talk about, value to whom, it really kind of hits home, because when I see patients every day in the clinic who have had transformational experiences and dramatic improvements in quality of life, reductions in the number of doctor's visits, medications they take, not having to travel with their CPAP anymore, I mean, you name it. It's really kind of, this is kind of the value to the person who's being treated. Broadly, when you kind of look at a lot of the real world or other kind of modeled studies, we're really missing the drug pricing in there in terms of what's there, or those that do include it really exceeds the willingness to pay threshold for so many. And I think what we need are better real world kind of studies, because we get very excited as we extrapolate out potential benefits from clinical trials, but our patients don't live in clinical trial environments. And I think there's been so much in the news about discontinuation rates of treatments, but also I think some of the untold story is the reinitiation. It's a very dynamic environment of people not just coming off of these medications, but coming back onto them, that we need a fuller picture of what's actually happening, but also to acknowledge through the lens of the patient, what does value look like to the healthcare consumer and to society.
Well, great. And what a perfect lead into the next question. We've talked about how these drugs are expensive. It's important also that we do remember that there is a difference between list price and what in the drug industry is called the gross to net, or the net price. after a deduction of either patient assistance or of rebates paid for formulary status to the PBMs. So it's important to think not just about the list, but also the net that we're dealing with. But what we're facing is a situation where a lot of people who could benefit from these drugs can't get them. Let's talk through some of the options that are being considered to lower costs and expand access. For example, outside the United States, some countries are treating GLP-1s as public health interventions. Should the US government consider getting more involved to bring prices down and to increase access, perhaps thinking about these as public health interventions? And what are the economic implications of all of that? Jeff, how about you start us off this time?
Well, as I have been, I don't want to kind of beat a dead horse here, but as I've been saying, I think that the way the U.S. government can get involved is by getting GLP-1s reclassified as over the counter. First of all, that will expand access. It will reduce cost. I mean, people to get to a doctor's office to get a prescription, that's an expense. It's not just in monetary expense, but sometimes they have to miss work, and it's an expense in time. And I think that, like I say, experience has shown when these drugs become available over the counter, there tends to be more price competition and prices come down. There's nothing that would prevent insurance companies from reimbursing people for out-of-pocket expenses for over-the-counter purchases if they think it's in their best interest to do that. Also, as far as safety is concerned, people would raise the question of, well, is that safe? Well, right now, for example, a teenage boy could, a 10-year-old boy could pick up a lethal dose of Tylenol for me at CVS and hopefully not take it. But there are a lot of drugs that are over the counter that, if not taken properly or taken into a greater dose, could cause a lot of problems. Ibuprofen can cause kidney damage, hypertension, cardiovascular disease. We go on and on. So I would prefer that these drugs be made over the counter, but a compromised position for people who are a little leery of that could be a category called behind the counter, which doesn't exist in the United States really, but it's common in Europe, where you got to get it from the pharmacist. So at least you have someone who could ask you questions and make sure you're knowing the proper use before they decide to sell it to you.
Well, not the core topic for today, but you're speaking to my heart. I've often thought we need a behind the counter regime like the Europeans have as a third way to allow us to titrate access to medicines and perhaps reduce cost and enhance access. But that's a side point for me. So how about Govind? Let me ask you to comment on this issue of GLP-1s as a public health intervention, and how can what is the role of the government in trying to get price down?
Before me, can we have, I know Jamie said that he'd like to comment, and then I can come back in.
Certainly, Jamie.
I just want to kind of highlight that some countries are doing kind of limited access to medications where they may treat for 2 years, for example, and then you kind of then run out of access. I think when we look at a chronic and complex disease like obesity and we say we're going to give you effective therapy for 2 years and then discontinue it, we're really approaching it the wrong way. If you kind of put it this way, we're going to treat your blood pressure for 2 years, and then we're going to cut you off from your blood pressure medication and see if we can do a low salt diet and walking. We know that this is not effective for the vast majority of people. And beyond it not acknowledging the complexity and chronicity of obesity as a disease, what we're really doing is losing the gains that are achieved through the health of helping people to achieve a healthier body weight and adjusting some of the cardiometabolic complications that are part of that. But also not acknowledging that there are weight loss independent effects that a lot of these medications may have on decreasing risk for disease long term as well. So I just wanted to throw that out there, that kind of giving people brief access and then limiting costs by cutting it off abruptly is probably not a great approach to mitigate expense.
And certainly either in our discussion or in the Q&A, we absolutely should talk about you as a clinician, especially that question of the rebound effect. And is there an issue on that with cutting off and then what happens metabolically to the body? Do you know, Jamie, you mentioned this, are there countries that have taken, that perhaps have more integrated, holistic healthcare systems that have really taken this view of we're going to fund access to these medicines for a certain cohort of people because we really do believe this as a way to reduce healthcare costs in our system and improve chronic disease outcomes?
I think many are really trying to work out how do we integrate this into lifestyle modification with integrated nutrition, physical activity, and patient selection, but really encouraging or facilitating, I should say, adherence and persistence so that there isn't loss on this. And I think there's such a multitude of ways or reasons in which people may not continue on these medications beyond typical GI side effects that we really need to explore that in a way to really promote kind of chronic use of evidence-based care in a way that actually improves health long term.
Terrific. Thank you. Govind, and then I'll turn to Tracy.
Yeah. The issue of access, I want to try to disentangle a couple of things here, is that, I think that it's crucial. It's going to be really important. I think we're all going to probably agree on this on the panel in general, to try to reduce as far as possible cost barriers to patients in accessing these medications. I think the tricky question is sort of what the best way is of doing this. We've heard from Jeff, maybe you do OTC. For me, my thinking about this is sort of how do you balance, and there are different ways in which you might remove cost barriers. You might have a third-party payer like insurance pay more, and then the question is obviously then you don't want it to raise premiums. Do you have a taxpayer subsidy or some other way of reducing cost to the patient through third-party subsidies from government or taxpayers? Another way you could do it is you could try to reduce cost barriers by reducing what drug makers are or manufacturers are paid for these drugs. I think that can make sense sometimes to try to do it that way. I think the tricky question there is about balancing incentives for future innovation in this space against near-term sort of maximizing access for patients right now. And then also, I think, as I said earlier, preserving those incentives to continue to generate data about the drug's sort of effectiveness for different indications in pragmatic real-world settings. So something that a couple of things that my colleagues' comments make me think about, on the question of OTC, something that I struggle with is, I think first, given that these drugs largely are still under patent, how much you're going to really be able to get the gains from price competition that you would get from a generic where everybody can get in the way you can with, you mentioned acetaminophen or any other OTC. So most other OTCs, the fact of it being still under patent, I think makes that trickier. The other is that I worry with OTC about where you're going to get the incentive to drive continued development of evidence once you get into that regime. For the question about, switching to something else, my flip side question is I'm wondering, to what extent should we think of that as the goal? And that's going to be different patient to patient. But are there some folks, to be provocative, for who something, and the cost of production of these drugs is actually really low per pill? Are there for some patients that having this on more of a statin type model is going to make sense, that it's going to be a fairly affordable, cost-effective drug that you take long term?
Great. Tracy?
So when I think about opportunities to address this problem from our government structures, from our government programs, I think about our current structures, and there are opportunities that we have even under our current government structures. So with, covering at least about half of the population. So from a Medicare and Medicaid perspective, Medicaid states can choose if they want to cover their Medicaid beneficiaries or not. Today we see about a dozen states that offer some form of coverage across various treatment types. When we think to Medicare and pharmacotherapy, there's a prohibition on the class of FDA-approved medications through the interpretation of the statute. So a lot of advocacy groups have been working with CMS, Medicare, Part D, to provide evidence and rationale to update that coverage determination. When we think about, there's opportunity for TRICARE coverage. TRICARE for Life actually just changed some of their coverage policy, so beneficiaries there have lost access to medication coverage, and there have been changes to the other TRICARE beneficiaries as well. So, given the populations that the government already serves, there's opportunity to improve access to care there. And of course, the goal is affordable access to care. Now, on the topic of the pricing of the GLP-1 class right now, it's been a quickly evolving area. You mentioned the $1,000 a month, but for most payers and even for patients that have access to some of the discount programs, it's at least a 50% reduction in cost. Now, we fully recognize that that's not attainable for a lot of people as well. That's still too expensive. So we do the goal is to still make these innovations more affordable. But as we look ahead, there are even more changes coming down the pike in regards to policies around most favored nation pricing. We've got the Inflation Reduction Act coming out quickly. We've got potentially oral treatments, or oral treatments are coming to market as well. So I think even in the next 3 to 6 months, we're going to see even more changes in this landscape, and pricing will continue to evolve.
And before I ask Jeff if he'd like to respond to Govind's remarks, I wanted to ask you: do you know if anyone has thought through the question whether using the CMMI demonstration authorities, the Center for Medicare and Medicaid Innovation Authorities, CMS, could do a pilot covering GLP-1s for obesity in spite of the statutory ban on coverage of obesity medicines in Medicare?
It is my understanding that CMMI is exploring that option right now, and looking at an obesity coverage model, one that would include coverage for lifestyle therapy, as well as access to medications, which evidence-based treatment options, and hoping to hear word in the near future on kind of what direction they're going with those plans.
Great, thank you. Helpful. Jeff, let me ask you if you wanted to respond to the earlier comments.
Well, I just wanted to allay Govind's concerns about that. If drugs are over the counter, that may reduce innovation, because most things Americans purchase don't require a prescription. And the fact that you don't need a prescription, I don't think is going to in any way, work against companies innovating to come up with better products to sell to consumers.
Great, thank you. So Tracy, I don't know how much you've looked at our sort of peer nations and how they're handling access, but what can we learn from how other countries are handling GLP-1s? Is anyone doing it right? Has anyone made a big mistake that we should also learn from as we try to go forward?
Yeah, we have taken a look at that, and I think Jamie was even alluding to some of the policies in the UK, where international markets are some of the national health systems are offering coverage with limitations and restrictions. The thing that we're seeing is that there's still oftentimes a lot of barriers to access care, even if coverage might be provided or obesity is more recognized as a disease, and oftentimes patients are left to still be responsible for cash pay models or a significant proportion of that. So while it's helpful, it's helpful that these models are becoming more prevalent around the world. It tends to still put the onus on the patient, where we really want affordable access to care as the standard, as it is for most other chronic diseases. So thank you.
Great. Would any of the other panelists have a particular expertise or desire to jump in on this international question?
Well,
I could say.
We'll do Jeff and then Govind.
I just like to say that it seems like we actually probably cover it better than most of the other countries. They are a little bit in the UK, I think also in Canada, and some of the other Anglosphere countries. But generally speaking, they're pretty restricted. Now, none of the countries prevent people from purchasing it off-label with their own money, but most of their health plans are not covering it. Even in Canada, it depends on the province, because the Medicare, which is the name for Canada's single payer system doesn't usually pay for prescriptions, but the individual provinces may kick in that area.
Govind, did you?
No, I think he's covered it.
Okay, great, terrific. Let's go to a topic that I know is on, I'm certain, a lot of our audience's minds, which is the question of safety. What do we actually know about long-term safety and side effects of GLP-1s, given that millions may take them for years or even decades? And I would ask in this connection, if we might touch on, if anyone has information or evidence, the issue I touched on with Jamie earlier, that question of what happens if one does stop therapy once you either achieve your target weight or just can't afford or to continue, et cetera. Jamie, in fact, why don't we have you start off?
Yeah, sure. I think just to put it into context, we've been treating diabetes with GLP-1 agents for about 2 decades now. And so we have a very kind of long runway with regards to kind of what's going on. And I think population-based studies kind of pretty much consistently show overall improvements in health and outcomes from a cardiovascular, cardiac, kidney, metabolic perspective, and emerging data on, for example, prevention of dementia. And so I think there are a lot of things that would tell us that overall these are safe and effective. But kind of just to kind of touch briefly on kind of what Jeff's been talking about over-the-counter access, these are still very powerful medications. This is not just something to treat a headache over the counter. This is something that has an overall impact, could be on not just your body weight, the quality of nutrition that you're consuming, your need for blood pressure, medications, diabetes adjustment, thyroid hormone. There are a variety of different moving parts that come if and when you change your body weight by about 20%, or there are changes in dynamics of kind of gut motility or a variety of different taste or food preferences with kind of baseline food quality not necessarily being where it needs to be. If you take somebody and dramatically suppress their appetite and induce satiety, there's a serious risk for certain groups or populations for developing not just malnutrition, loss of lean mass, frailty, fall issues. So I think there are a variety of things we need to consider in how these medications are used, what care looks like. Because I think if we conflate access to drug with access to quality multidisciplinary care, we're going down the wrong path altogether. These are very effective, game-changing medications, but they need to be used appropriately. And given the wide variability or heterogeneity in terms of both response from a clinical, never mind just the weight, but also clinical and side effect profile, we really need to individualize care. And I think that's something that's really important as we look through the lens of what does long-term safety look like. It's creating programs that have patient-centered care where we're making sure we're not just giving them drug, we are providing a framework for success, and we're monitoring that at population levels.
Jamie, as a clinician, could you talk a bit about what you see as any safety issues? You touched on this briefly. Lean muscle mass loss versus fat loss, issues of vitamin nutrition deficiency, perhaps. As a clinician, what are you seeing out there? And is this solved by just a very good holistic patient-centered primary care home, or how does one deal with this?
Oh my goodness, this could fill up the whole rest of the of the webinar. I think the challenge is in terms of how people are getting access to treatments like this. I think we've unfortunately normalized people just being able to go online, interact with some kind of clinical pathway, and then have these things shipped to their homes without any baseline assessment of nutrition intake and quality preferences, what's going on. Are you having any side effects that is impacting how you're eating? No matter how we lose weight, be it through diet, lifestyle intervention, bariatric surgery, or highly effective pharmacotherapies, about a third of what we lose is going to be lean mass, and there are going to be certain groups who may be more at risk for that. Promoting adequate protein intake, physical activity, resistance training, these are all part of that integrated care that we've been kind of talking about that's really needed as part of this. And so those are potential safety or risk issues, particularly as we look at providing these medications to advanced individuals who are older adults who may have had history of heart attack or stroke, who may have inherent frailty. This is a population we need to make sure is getting appropriate nutrition and lifestyle assessment and longitudinal support, not just access to drug.
Great, very thoughtful. Tracy, I saw you nodding there as Jamie was talking. Would you like to chime in on this?
Yeah, I couldn't agree more. And we hear from patients every day. It's the community we serve, and we find that the patients that that struggle are ones that don't have wraparound care, who aren't supported, who don't have a clinician that is working with them to determine what their goals and their health needs and should be. And this is a patient community that has been left on their own to figure it out for years and years and years. And really, these new innovations and the elevation of understanding obesity is a complex chronic disease is the first time that a lot of people have ever experienced what quality evidence-based care can look like and feel like, and how their lives can be changed and how their health can be improved. But not everyone has the luck of finding a Dr. Jamie, right? Not everyone has that fortune, and a lot of people are still left out there to struggle on their own, and they are turning to online programs that might not be able to provide that support, or they're getting help from their sister's friend, or they don't know how or where they can find this support. We're trying to get the word out that good quality evidence-based care is available now. There are a number of options, and trying to help people down that journey, and also address the barriers that they face along the way, is I think from the patient community and the provider community that we work closely with, what we're doing on a day-to-day.
Great. Jeff, as one of our other clinicians, any perspective on the safety questions here?
Well, I don't disagree with what the other clinicians have said at all, but I do disagree on the question of autonomy. So, first of all, according to the CDC, actually, I think it was according to the Consumer Choice Center, out of the 600,000 calls to the U.S. Poison Control Center between January and May, 11% were for Tylenol overdoses, and that is an over-the-counter medication. So over-the-counter medications should not be considered benign, and people need to use them wisely. But I don't think we have a right to force people or to deny people the access to a drug because we want to have control over how they're going to use it. Now, there could be a whole lot of other regulators in its place. For example, the pharmaceutical companies are going to be concerned about their liability. So they may decide to restrict who could buy it over the counter, or they may have very stringent labeling. Again, we could have this compromise of behind the counter where a pharmacist could interview the potential consumer and decide whether or not the pharmacist could decide whether or not they want to sell it to the patient, because they may think the patient they're not comfortable the patient's going to use it wisely, and that would be their choice. But in general, even though all of us would like to see people use medications the safest and wisest way, we don't have the right to restrict people from self-medicating. That's a fundamental right, which I discuss in my book. And also, keep in mind, it's already happening. We are all aware of the so-called rogue sites on the internet where people are buying GLP-1s. And of course, we don't even know whether these GLP-1s, whether they're impure, whether they are even what they say they are, because we don't know where they're coming from. It's like a black market. So it already exists. And I think if people were able to get it over the counter, then at least they'll be safer and regulated by the marketplace and by liability laws.
Great, thank you. And I've got another clinical question, so I'm gonna particularly focus on our clinicians for a second, but others, please feel free to contribute if you'd like to. I hinted at this question before in exchange with Jamie, which is that there is research suggesting that weight can be regained when treatment stops. Is that true? Does the data show that? Should these GLP-1s be considered lifelong therapies? What have you found are good strategies to transition patients off of GLP-1s? Or I've seen instances of tapering, for instance, regulating dosage down. And then we've talked, as Tracy mentioned, about lifestyle and other therapies to help maintain outcomes, sort of good healthy behaviors as a wraparound to the use of them. Jamie, you want to start us off on this?
Yeah, sure, I'll start there. When we look at data from clinical trials like Step 1 extension, where people are treated effectively with semaglutide, they lose about 17% of their body weight, and you follow them out a year from discontinuation, abrupt discontinuation, they regain on average about 2/3 of the lost weight. And I think for many people, this exemplifies kind of the chronicity of obesity as a disease, and you stop a highly effective therapy and you have recurrence. This occurs in the real world all the time. People change employers, lose access, there are new restrictions on coverage or additional hoops to jump through, never mind potential issues with supply and other things, where people now don't have access. And this is a real challenge because abrupt discontinuation of medications like this, before you even see weight recurrence, there's rebound in appetite, potential also increases in glycemia, blood pressure, and a variety of different things that are not just weight. I think because these medications impact more than just body weight alone, we need to look at this through a much broader lens in terms of how it's going to impact health and quality of life overall. I think we really need to kind of look at this as chronic disease management, where we can focus in on highly effective treatments, including bariatric surgery and pharmacotherapy, but acknowledge that these may not have to be forever for everyone, and that we should invest in more research in terms of what step-down therapies could look like, or adjunctive therapies or changes that could allow people to maintain their weight-reduced state, but also hopefully the health gains that they get as part of this care.
Well, you and Tracy in particular, I think, focused on this. I've gotten, as people have been submitting questions online already to get ready for in a minute when I do open things up more. The number one question that we've been getting so far relates to what we're talking about here, which is for people who hope not to stay on GLP-1s indefinitely. What have you seen help them make lasting changes that support their health after coming off the medication? Tracy, from your members and the community that you work with, what have you seen?
Yeah, so I mean, I think it's also important to just restate the fact that obesity is a complex chronic disease that someone has to manage over the course of their lifetime. So similar to other chronic diseases, we wouldn't tell someone to stop their diabetes medications and expect their hemoglobin A1C to stay lower than where it's at, right? So, or their blood pressure or their cholesterol. So this question is a little, confounding to me that, like, of course, it's true that someone's weight regulation would readjust after going off of the therapy. So it's to the question of staying, being able to come off, that research is underway. I think there are a lot of studies being conducted right now looking at various approaches to that. And so we look forward to that data, to those findings. But I think that one of the key points is that a patient work closely with their trusted healthcare provider that knows how to manage obesity as a disease chronically and uses the full spectrum of evidence-based treatment. So some might do very well paired with a nutrition lifestyle regimen. Some might have to look to other interventions as well. So I think the recognition of the complexity of the disease and well-managed care and that relationship is key.
Great. Jeff, would you like to comment here?
Well, I just like to give a surgeon's perspective here now, just to consider the counterfactual. People who undergo bariatric surgery also, a significant number of them end up gaining a portion of their weight back, up to 25%, depending on the type of procedure used. And bariatric surgeons will try their best to get their patients to kind of change their eating habits and their lifestyle choices to decrease the chances of that happening. Nothing is perfect. But on the other hand, with GLP-1s, at least as the evidence is to this point, you can continue on them indefinitely. When it comes to an operation, if it doesn't work, I guess you go to GLP-1s or you have another operation.
Well, thank you for that. And just for the audience, again, be thinking of your questions and submitting them. Let's close for this portion, though, with a tricky ethical question before we open it up. Some say that GLP-1s reduce stigma by validating the biological aspects of obesity and empower people to get healthy. But some worry that GLP-1s will make people complacent and steer them away from important non-medical strategies like diet and exercise. Where do you all, our speakers, fall on this continuum? I guess Tracy, why don't we start with you? I think you've had a good bit to say on this question, but then we'll go around and close this section out.
Sure. I think the way that you opened that question, if someone had a full understanding of the first part of the biological aspects They wouldn't be asking the question about someone being complacent in their treatment. So I think that from the patient community perspective, that this a claim about someone being complacent is it's short-sighted, and it's not really based in the evidence. Where we know that when people get access to obesity treatments, they're able to be more engaged in their health, more engaged in activities, more engaged to a point where, because they feel better, because they're moving better, because they're able to do the things that they've been wanting to do. And so it's a view that is simply wrong.
But it is interesting. There's not a lot of stigma with taking a statin for high cholesterol. But I'll tell you, just being out in the social world, there is quite a bit of stigma for people who, oh, you've lost a lot of weight. How did you do that? Oh, I took a GLP-1. Are you taking the easy way out? I mean, I think we've all seen and heard those kind of interactions. It's interesting how we think of these two clinical disease-oriented, like, genetically based often aspects, and we have very different reactions in terms of societal stigma. Jamie, do you want to chat on this one?
Yeah, I think it's incredibly challenging where people are limiting their own access to evidence-based care because they're worried about what others may say. And it's that time of year where families are going to be gathering for the holidays and people are going to say, no, really, what's going on? What are you doing? And I think, we even go through kind of coaching points with our patients at this time of year. What are your talking points going to be when somebody asks you what's going on? Because I've seen over the years, someone will say something at a family or work event, and the patient will stop something that's been working really effective, not just to lower their weight, but improve their health. And I think we need to kind of work on how can we, as society, decrease this kind of inherent weight bias and stigma that exists so that we can work on having people feel healthier in general and have a better quality of life. I think the key to highlight is that these medications facilitate and not replace health behaviors, because as Tracy was just saying rightly there, this is something that is part of, decreasing things that have unfortunately been challenges for people on a health journey before for healthy weight, be it appetite, food noise, be it additional other challenges where they need insulin to control their diabetes, which is kind of promoting weight gain. These can be additional tools to help people to achieve better health long term, and we need to work systematically at how can we decrease the weight bias that I think many people unfortunately have.
Great. Thank you. So we've covered a lot of ground, and I know the audience has questions. So without further ado, we're going to turn to the Slido. And as a reminder, you can find the Slido window embedded directly below the video player. We have already been getting some questions. One is related to the topic we've spent a good bit of interaction on, which is, if GLP-1 receptor agonists were to become available over the counter, how could regulatory bodies ensure consumer safety, clinical appropriateness, and health equity while maintaining pharmacovigilance standards comparable to prescription oversight? Very interesting question. And Govind, let me ask you to comment here. And perhaps think about, does AI in any way change the game on non-prescription sort of phase 4 real world data monitoring?
Yeah. So my initial reaction on this is that sometimes I think focusing, and we've talked about this specifically on over the counter, is a little narrow. I think the question in some ways is sort of, to what extent should we require sort of consultation and engagement with a clinician or something like that as a precondition to access? And we have different views on the panel about this. To me, in some ways, the two initial reactions I have is that I actually would like empirical evidence about what the effect of these different access regimes would be on health. So I would almost like to run a trial where I compared two different access mechanisms and saw how people fared in terms of health under each one, as opposed to, we can have our conjectures or our value judgments about what rights people have, but I'm also interested in factually what difference it makes. My other reaction on this is that I think some other countries, going back to international, I think are, unfortunately for a US audience, better placed than we would be, I think, to be able to have regulatory bodies that maintain those standards, ensure these other things, in part because they have much more robust sort of data sharing, like what I saw with the National Health Service, which I wouldn't say is a model in every respect, but with respect to data during COVID was able to do compared to us, it was remarkable how much higher quality their data generation was able to be often. I think Israel was similar. I think there are other countries, Taiwan, Singapore, that I think of as really strong models in this area. And so I think it could be done to sort of relax potentially the gatekeeper or advisory role of having somebody in the loop before you are taking these potentially. I would like to see, empirical evidence of that. But I think in some ways, doing it in a setting like the NHS, where everybody does have this wraparound from a clinician, looks really different than doing it in the US, which has such a fragmented system, and many folks have no PCP at all.
Jeff, did you have anything you wanted to get
Yeah,
in on that one?
yeah. Well, first of all, we already get so many medications over the counter that obviously had to go through an approval process and a labeling approval process. And so in terms of quality control, plus, the liability system and reputation of companies, these are all good regulators of the safety of these particular drugs. If I could go back a little bit to the last question about stigma. If there's one really big stigma, it's attached to substance use disorder, like alcohol use disorder, opioid use disorder, stimulant use disorder. If this was available over the counter, an individual who was concerned that maybe they're beginning to, they notice they've been drinking too much, and maybe a couple of their friends have talked to them about it. Just think of how much easier it would be to pick up one of these drugs over the counter. Nobody has to know about it. It's very discreet. And then you could start to regulate your use of the substance. I mean, there's a lot of evidence suggesting that abstinence-only treatment is among the least effective options, and treatment that gets at moderation and managing moderation seems to be very effective. So here's a way of kind of nipping substance use disorders in the bud by having people avoid the stigma of going up to a doctor and saying, I think I have a drinking problem. Can you help me?
Great, thank you. Jamie, I wanted to ask you a question that has come in from the audience, which is, we've seen a lot about drug compounding in the GLP-1 context, and FDA is actually, in just the last couple of weeks, seemed to be getting more active as a regulator in this space. First, could you explain to our audience about drug compounding? But would we anticipate that compounded GLP-1s would differ from brand name GLP-1s in their effects, both on weight loss and in terms of reward sensitivity, food noise, cravings, appetite, et cetera?
Well, this is a tricky situation. So the compounding era of GLP-1s began during the shortages, with kind of loopholes, kind of circumventing, I believe, intellectual property, where compounding pharmacies were able to sell versions of these medications. There's varying levels of quality of evidence saying that the medications that are sold by many compounding agencies are not containing kind of what's stated there. I think the challenge is in terms of how patients may be accessing medications through compounding pharmacies, either through online agencies where they're purchasing it themselves, versus a clinician prescribing this from a compounded pharmacy where they're getting guided initiation, dose titration, troubleshooting with regards to symptoms, and how to kind of use these medications in a way that improves their health and is not just trying to get them on the medication in the highest dose. And that's all as a segue to, do these medications work as well? In certain instances, we're not really sure, are patients taking the active ingredient or the active medication, and how much. Many patients will come in for consultations on, I'm a non-responder to this medication, and they've bought a compounded version. You say, well, what did you take, and how much did you take? And they're like, well, I don't know, maybe 5 units, 10 milligrams, I'm not even sure. And I think that leads to a lot of confusion when patients don't receive clinical guidance on what they're taking, how much they're taking, and how to increase the dose in a way that works with their body, given that many of the not just beneficial effects, but also potential side effects are dose dependent with these too. So not to give too much of a politician's of an answer with regards to what does this all mean, it's a challenge to know what patients are taking. I think the inconsistency with labeling and dosage leads to not just confusion, but also opportunities for misadventure with regards to adverse effects and people not reaching clinically significant goals.
Great. Tracy, could I turn to you?
Yeah, I would just echo that in this particular area, there's such wide variation in what is available to patients, right? Someone is, likely in the situation where they don't have affordable coverage, through their health insurance. They want to improve their health and quality of life, and they're looking for alternative options, right? So the compounded GLP-1s have become very, very popular and high demand. Now, when we look at this space, there's this wide variation of everything from, the 503B, wholesaler compounders to the 503As, which are the state-regulated compounders, all the way to just buying something online, right? So there's this wide variation of compounding that's happened under a regulated model, as well as illicit drug dealing, essentially, where people don't even have to have a prescription to get some of this stuff, or they're going to a research grade or a peptide pharmacy. Like, people are struggling in this space to figure out what is the best option for them, and it is an area that we focus on a lot at the Obesity Action Coalition. But when patients come to us and they say, which one should I try, or where should I go, to Jamie's points, we can't answer that because we don't have the data. There's no way to say this one's safe, this one's not safe. This vial that you get this month is safe, but this vial next month might not be safe. We just don't have the data.
Great point. Jeff, did you want to contribute on this?
Yeah, I don't disagree with the clinical assessments of Jamie or Tracy, but from a policy standpoint, again, I think this is paternalistic. Compounding pharmacies are not regulated directly by the FDA. They're regulated by the state pharmacy licensing board. So if there's any problems with the compounding pharmacies, there's certainly an avenue to address it. But also, experience has shown us that people, when they do their own direct-to-consumer shopping, are much more conscientious in doing due diligence. I could tell you as a clinician, a lot of times my patients, when I ask them what medications they're on, they tell me, well, I'm on a blue pill, a green pill, and a striped one. And well, what are they for? I don't know, but my doctor tells me to take them, because people just do what the doctor says. But when they're doing their own shopping without a doctor, they really are conscientious about doing due diligence. And I've written about this. I think I would like to see the FDA modify its regulations on compounding pharmacies. Right now, compounding pharmacies are not allowed to compound something that is essentially the same as a commercially available product, except in cases of shortages. And I think they should be allowed to, and they should compete. I mean, obviously, the pharmaceutical companies could make a really strong case that they have better quality control and dose management, except, of course, we need to respect the patents. So I'm talking about drugs that are off patent.
Great, thank you. I just wanted to find, there was another question that got a lot of traction was, to what extent should Medicare and Medicaid programs absorb the rising fiscal burden of GLP-1 coverage and for obesity? And how might federal pricing negotiations or utilization controls influence sustainability and public accountability? Govind, do you want to kick us off on that one?
Sure. Yeah. So I think that they should, but the question presupposes this idea of the rising fiscal burden of GLP-1 coverage for obesity. And one of the challenges here is that, as we've been talking about earlier, sort of in an ideal setup, you would have actually Medicaid or Medicare be comparing the burden of GLP-1 coverage to the burden of paying for all of the other challenges related to long-term chronic disease management. Unfortunately, because the payment horizon is different for these different things, your state Medicaid program is budgeting year by year, and they are terrified about the sort of cost year over year. So I think the tricky question is, within political constraints, is there a way, with insurance churn, right? We were talking about insurance companies should, and this includes Medicaid, ideally should see the value to them in doing this, but they don't. If I'm on Medicaid in Colorado and I get this, and the person who's going to be saving money long term is going to be Medicaid in Texas or Oregon, there's not that same incentive to save costs over a long horizon. I think so this is where I think the issue of federal pricing negotiations, utilization controls come in. To me, I think utilization controls I struggle with because they're a kind of second best. To me, I think, look, you have these drugs that are actually very cheap to manufacture. You have some people who wouldn't be able to pay the sort of current patent price, but would be able to pay something less. The patent holder would have an economic incentive to sell to them, given their actual ability to pay. Can you work toward, in some writing that I've done with colleagues, something like a subscription model where the state Medicaid or state employee health insurance program pays to cover everybody who clinically is eligible and would benefit to get their Medicaid or their employee pool access without having to have utilization controls that are very tight for a drug that actually isn't all that costly to manufacture. It could be a win-win, I think. The federal pricing negotiations is really tricky because it gets to the question, Jeff said, we have to respect patents. I think the question really is about, for me with patents, is I don't think the current patent system is optimally striking the balance between innovation and access, but I don't have the answer for you all about what system would do that. And I would like to see, thinking about how to design pricing negotiations in ways that improve access while appropriately incentivizing innovation that's actually beneficial.
Would anyone else like to contribute on this question, Jeff?
Well, I got a lot of mixed emotions about this. On the one hand, if Medicare and Medicaid are going to pay for this, I think they should negotiate directly and use the model like the most favored nation status model. They shouldn't they should make the pharmaceutical companies have to pay the best, give them the best price possible. But on the other hand, if this was over the counter, then I don't think the insurance companies should be compelled to reimburse people. And experience has shown, for example, birth control pills were over the counter and not reimbursable by most insurance plans until the Affordable Care Act was passed. And if you looked at, and we published on this at the Cato Institute, if you look at the price trend line, the prices of birth control pills, I'm sorry, they were prescription only, but they were not reimbursable by insurance. The price of birth control pills were coming down, following the same trend line as overall prescription prices were coming down. As soon as they became reimbursable and essentially costless to the end user, the prices started to go up dramatically. In fact, they exceeded the trend line of prescription drug prices increasing. So a downside of reimbursing for over-the-counter GLP-1s is that it's going to make the prices likely go up because the person who's purchasing it is less concerned about the cost since somebody else is paying for it.
It is interesting. One of the great challenges in healthcare policy and financing in the United States is when you pay for something, the cost goes up. We also, in our health, when we do our health policy debates and health cost debates, we always look in the rearview mirror. We're always very focused on the current status and do not understand the dynamic nature of innovation in the economy. I remember back in the day when a cure for hepatitis C came out, and all that it was, I think it was priced about $86,000. All the world was in hysteria about it. It would bankrupt every Medicaid system. It was going to destroy healthcare in America, even though it would cure all of these people. And again, not understanding the cumulative and concurrent nature of innovation. I think 6 months later, a very comparable Hep C cure came out. and the net pricing of those products fell through the floor really within months of this mass hysteria. We now possibly could be having oral GLP-1 soon, which I don't know, but I would assume would likely create increased cost competition and lower net prices, if not lower list prices. But Tracy, let me turn to you on my ramblings there, but also any thoughts you have on this Medicare Medicaid question.
Yeah, I was just gonna build off of your comments there in regards to, I'm optimistic that we are headed in this direction. There is not a class of medications like this to date that has the effectiveness and the growing number of indications that are coming down the pike, and the potential population health effects that patients can benefit from. So that's really exciting. It's really exciting from a patient community, from a clinician community. And these policy reforms that are coming up, I think will affect the pricing landscape. The orals, as you mentioned, IQVIA data also shows us that there are upwards of 150 molecules in research and development. Competition is coming, and as we think about the value that these innovations bring to the system, I challenge the audience, I challenge all of us to think about better modeling. How do we think about this class differently when we're affecting so many indications, other disease states, other organ systems and populations? How do we think about it differently? Because maybe it's not all under one umbrella. Maybe we need to think about the value that it brings to, across healthcare. I already mentioned we have early data on reducing ER visits, hospitalizations, decrease in other chronic condition. So I think the data is building, and I'm optimistic we're heading in a better direction that will ultimately lead to better access to care for patients.
Terrific. We had a really interesting question that I'll confess I haven't spent enough time thinking about, which was, obesity is such an issue, one might say a crisis for youth under the age of 18 in our country. What do we see as the future for use of these therapies for those under 18, and what are the potential issues that raises, as we think about SCHIP, Medicaid, and the youth obesity crisis? Jamie, how about if I ask you to first think about this?
Sure. As a caveat, I'm an adult endocrinologist. I do not treat people under 18, but I'll take a stab at this. I just want to kind of put into context that 1 in 5 children and adolescents are living with obesity now, and the thought is that by 2050 it's going to be 1 in 3. So we need to take action, and we need something that works and is effective. Data suggests that this is not just sedentary behavior, that there's a large nutritional and other kind of factor process that goes into this, so that it's definitely not a one size fits all, and it's not a single approach that's going to be helpful. In the context of drug therapies for adolescents, there are approvals for semaglutide, currently liraglutide for people down to age 12. The thought, though, is that, well, are we going to start people on treatment at a young age and then continue this indefinitely? I think many people wrestle with this. What are the long-term potential issues with people who are still growing and developing, starting a medication like this? But when you look at the rising prevalence of type 2 diabetes, steatotic liver disease, and other health complications amongst youth, what's going to happen if we don't intervene? I think the advent of oral agents, small molecules, and things that can be taken more effectively or more easily than having to give a young person an injection either daily or weekly will likely revolutionize things. There are also monthly and other options coming up. So I think the evolving landscape will hopefully provide options that are acceptable to the variety of people who are challenged with obesity and who could benefit from earlier intervention. My concern is that we're waiting too long, and that there's an opportunity to intervene during adolescence before we turn into a young adult with severe obesity-related complications.
Govind, would you like to comment on this?
Yeah, just thought this is a nice context for me to raise this thing that I've concerned about and interested in, which is how to drive the incentive to conduct clinical trials to have robust evidence about benefit and risks in pediatric populations. I don't think that's a reason to deny access, but I think it is a reason where, so many pediatric medications we use off-label or without data in that specific pediatric population. And I think I completely understand why as clinicians we often, I'm not a clinician, but clinicians need to do this, but it has the downside that I think, you don't get that optimal data that could help really design the best treatment path. And the flip side is I also think that it can then generate a fertile environment for mistrust or speculation about effect. And so I'm interested actually as a sort of question also for the clinicians on this in general, like, is there adequate incentive right now to be doing clinical trials, pragmatic clinical trials, other work in this space to understand, say for these drugs in that under 18 population, what is the best way of going forward? How can we get to a space where we get that kind of information?
Jeff or Jamie, do you have thoughts on that? I don't know if you've been involved with clinical trial work and the industry and how they fund those studies.
I haven't. I would defer to Jamie, but I would think that with childhood obesity being such a big problem, there's going to be a demand for research in that area.
Let me ask one other question that that we've gotten in is again around the question of data generation is, have we seen any data yet on the comparative effectiveness of different diet control mechanisms, intermittent fasting, and or the comparative effect, and then longer term, as well as a concern about longer term digestive effects such as GERD and slower digestion as a safety. So two separate ones. One, have we seen comparative effectiveness data about different methods, including the GLP-1s, putting head to head? And then the second is, have you seen concerns about longer term digestive effects, GERD and slower digestion? Open to anyone who's interested in chiming in on either.
So if the question is about head-to-head comparativeness for kind of effectiveness of the therapies, we're fortunate to have direct head-to-head comparison of tirzepatide and semaglutide showing greater weight reduction with tirzepatide versus semaglutide, but we also have longer experience with semaglutide and additional cardiovascular and other data that's not yet available. I think kind of it paints a picture of what does the future need to look like for demonstrating value and effectiveness as clinicians and payers and policymakers decide which is a preferred treatment for one versus the other. And then what are the future ethics of then having placebo-controlled trials when we know that there are significant health benefits beyond weight for treatment with these agents, and what do active comparative trials look like in terms of how do we as society or policymakers or payers evaluate active comparator trials in this space? So I think there's a lot that needs to be explored.
Great. We got another question, again, focused on OUS. The United Kingdom is combining GLP-1 with lifestyle change programs, which I think both Jamie and Tracy mentioned before. Are we not able to get to this point here in the United States? Or is Wegovy, or are Wegovy and Mounjaro just the new Botox? Was the question. Not my words, from the audience. Anyone?
I could
And then Govid.
start there quick. I think that the United States is exploring coverage models to this effect, or to include, evidence-based interventions like these. I think the thing, though, that we, from the patient community, we really want to ensure is that as our country develops models of care to address obesity, is that they are included within our health systems, healthcare delivery structures. For too long, patients have been left on their own trying to figure out their care. Patients living with other chronic diseases don't have to do that. I don't have to go online to find my chemotherapy if I'm diagnosed with cancer, right? So it's almost creating. We want to ensure that the models that are developed and the models that are offered are affordable and accessible to people, such that we don't actually create a two-tiered system where, well, if you have the money and you can go get it, well, you're fortunate. If you don't have affordable coverage, then, well, you're out of luck.
Great. Govind, did you have something on this one you wanted to raise? And then Jeff?
I'm happy to have Jeff go first.
Well, I would just like to say that from the bariatric surgery experience has been that people who undergo bariatric surgery, if they have it combined with a lifestyle change program, it seems to be more successful and is less likely to gain weight later. So, but on the other hand, to whoever asked the question, will it be just another Botox? I have no problem with that either. I think that's moralizing. People, maybe people don't want to go through lifestyle changes, and I look at this as a form of harm reduction. Just like having naloxone available for people who want to continue to use illicit opioids. Also, I want to throw something else into the mix. AI is exploding, and I myself, as a clinician, have gone on AI platforms like ChatGPT and entered a lot of interesting information with technical language, and I get back something that could be in a textbook. It's impressive. So as more and more people are using this and hopefully able to access it over the counter, I would think that a lot of people are going to take advantage of AI and get advice on how to use it more safely and effectively.
Govind?
Yeah. So I really liked this question because I like the question about also, is it the new Botox? And for me, what I struggle with ethically is I see the pull both of, and I'm interested to have Jamie's voice in on this as well. I see the pull, I actually very much see the pull of Jeff's idea that, look, it is, some people may want to take GLP-1s as part of a comprehensive lifestyle change. And some may just, personally want to take them, without doing that. And, who am I to say under what circumstances they should take them? From my point of view, I think the reason to me why it can be legitimate to, whether it is to incentivize through payment, lifestyle change, or to incentivize through payment or regulation, doing a clinical trial on this, is that even though sort of access in the Botox model, as it were, I think may be better than no access. Again, I would actually like to see empirics on that, but my gut guess is that there could be advantages even of access to GLPs for eligible patients under a model of kind of very thin support. I think it could be even better to have access in a more robust model. And I think it can be legitimate. I think this is where we may differ in sort of how much we want to push people that way. If you can get much better by developing something more robust than the Botox model, sort of what are the levers that are legitimate or not legitimate to pull to get there? And who's going to want to put up the money to make it not the new Mounjaro? Again, I come back to the fact that in the UK, their different system of payment makes it easier for them to do that. Who is it who's going to want to put up the money to have the lifestyle change programs? But in a certain way, the manufacturer and the lifestyle change programs are in kind of competing for the same consumer. I think it's a really challenging and really interesting ethical and policy question. And I would love to hear Jamie, as a clinician who prescribes in this space, your thoughts as well on this.
Yeah, I think going down kind of the path of talking about this in terms of a Botox environment is even more stigmatizing, I think, for obesity as a disease. I think there will be a proportion of people who want to use this medication to control small amounts of excess weight or to promote weight maintenance across life changes or the lifespan. But I think when we're looking at the problem of, as imperfect as BMI is, more than 40% of the adult population living with obesity, more than 1 in 7 women aged 40 to 60 living with a BMI over 40. This is not just about kind of a cosmetic discussion. This is a public health emergency about how are we going to treat obesity with highly effective therapies that don't just decrease body weight, but also improve health long term, and will likely improve the productivity in a variety of different things in society as we look at this in economic terms. So I think there's so much that we need to look at because this is really a paradigm shift. And I think the policy challenge is not really like whether to use them, but how to do this in a more responsible, equitable, and really sustainable way.
Excellent. Excellent. Well, unless any of the other panelists have anything further, I don't think so at the moment. I'd like to thank you all because we're getting close to time. I learned so much from this discussion, especially having people who bring diverse backgrounds and fields of study to the table. For me, I really was surprised by the level of alignment around the promise of GLP-1s as a public health intervention and a health intervention for individuals. I was also taken by the fact that while we all are very concerned about the cost and access issues, it doesn't appear that any country or any system has really solved this vital question yet. But as we talked about it, it may be that innovation and additional competition will make this something of a self-correcting measure in the future. Um, there also seemed to be a fair degree of alignment around the long-term, a fair degree of comfort on the safety questions around the GLP-1s, but a real concern about, from some of our panelists, around surrounding the GLP-1 with appropriate holistic medical care, not just around behavioral modification, but also around ensuring that individuals who are on GLP-1s are having other aspects of their healthcare be looking for any possible effects on the systemic physiology of the body from taking the GLP-1s. I'd like to thank our speakers for sharing their time and insights, to thank all of our viewers for your thoughtful questions. I hope this conversation has brought some clarity and transparency to the ongoing debates around GLP-1s. And finally, today's event has been recorded, and everyone who registered will receive a link to the recording as soon as it's available. So please feel free to revisit the discussion or share it with others in your network. Thank you again for spending time with us today. We look forward to seeing you again soon. Thank you.